service. And so thus she is again doing real life clinical problem solving in this moment. So she unfortunately won't be able to join us. But I'm very happy to see you all and really looking forward to getting to think through a case together today. For those of you who are longtime VMR devotees, our case presenter for today is someone who you may remember from the early days of VMR with Dhruv. I don't see Dhruv in the waiting room yet, but we'll give him a little bit of time to join. But in case he can't make it, if anybody has a case as a backup that they'd like to present, it is highly encouraged. Let us know, and we really look forward to hopefully having a case today. But yeah, we can give him a couple minutes. Oh, we got some more folks joining. Hello, Yusuf. Hello, Laura. I was saying we're just waiting for our case presenter, but I don't know that they're going to be able to make it today. So we shall see. But does anybody potentially have a backup case that they want to present? Yusuf, thank you. Yusuf, Dhruv is usually right on time. So I'm worried that maybe clinical responsibilities or something is preventing him from being here. So Yusuf, maybe why don't we just do your case today? And given that it's just me, if I talk for 30 minutes straight, that'll be painful for everybody. So we will make this more of a dialogue conversation. I'll try to solicit thoughts from the group. If you have your video on, I may come to you and ask you to contribute, or if you share your thoughts in the chat, I may ask you to share more verbally. But we'll make this a dialogue. If you hear me say that and you're like, I'm turning my video off, that's totally fine. It was welcome for you to keep it on. Again, the goal here is not to show how much we know. The goal is to find the edges of our knowledge and push them forward just a little bit here. So low stakes, high fun. As I always say, I can't promise that we'll solve the case, but we'll at least be able to analyze the case. And if we do that well, we'll learn something along the way. Oh, I see videos coming on. Hassam, thank you. This is very exciting. All right. Well, let's see. Kachal, I'll let you take over the whiteboard. Gia, thank you for scribing. And Yusuf, I'll let you get us started.
Hello, everyone. This case is not written down, and I currently have it on service. So I will change the information a little bit, and I'm just going to give you the information off the top of my head.
Perfect.
So bear with me, and you can also ask me questions. If I missed anything, please feel free.
Sounds good.
So,
Yeah. Just feel free to tell us a story.
yeah, this is a 30-year-old gentleman originally from India, presenting for shortness of breath. To give you just a little bit of information, he presented to a neighboring hospital for shortness of breath and was found to have diffuse lung nodules. And I'm going to stop right there.
All right. So we have shortness of breath to start off, but we actually have diffuse lung nodules. So I am going to open it up to the group. No expectation that anybody has an approach to diffuse lung nodules. So we're going to think about it this way. What are some categories of disease that you think about that could cause diffuse lung nodules? Again, not a focal lung nodule, but diffuse lung nodules. Nikita, I see, is mentioning TB already. Nikita, could you share a little bit more about sort of how TB is coming to mind and anything else that you think about when you hear TB and diffuse lung nodules?
It's been a while since I've been here. Just sorry about TB because the patient's from India. I do not know if TB would fit the picture because if we're describing nodules, I do not know if it would fit the miliary TB picture. But if I were to remove nodules out of place and think about something diffuse, I would think about TB in this case.
All right.
But yeah, that's the analogy.
Excellent. Excellent, Nikita. I think that is absolutely spot on. I see Yaz and Kushal both mentioning some of the autoimmune and autoinflammatory diseases. Maybe Kushal, maybe I can come to you. What about those diseases makes you think of them when you see diffuse lung nodules?
One, because it's more common to have them, as well as they can also present with shortness of breath.
Excellent. Yeah, absolutely. Absolutely. And I think, honestly, at this point in the case, the making progress on diffuse lung nodules, there's a pretty, I shouldn't say an exhaustive differential diagnosis, but there is, a relatively well-defined DDX here. But there's two features that can really help us make a lot of progress here. One is going to be the pattern of distribution, and two is going to be the presence or absence of cavitations. Okay, so let's just talk a little bit more about that. Does anybody have different patterns of diffuse nodules that they think about, or any terms that they've heard thrown around before when radiologists have maybe characterized the pattern of distribution of the diffuse nodules? Yeah, Tansu, tell us more.
So I actually just know what I wrote, those two types of nodules. One of them is centrilobular nodules that's close to the bronchiolar tree. And infections such as, I think, TB can cause that type of centrilobular nodules. And when it comes to perilymphatic nodules, I'm thinking of like the lobules of the lung and the nodules along the lines of the fissures of the
Yes.
lung. And in that, I'm thinking of like pneumoconiosis as an example that could cause that kind of a pattern.
Yes.
Yeah, that's what I remember.
Excellent, excellent. Those are perfect examples. I think there is a list of different diseases under each of those categories, but really what I want you all to understand is the concept behind the different patterns. So you'll hear radiologists describe different patterns, like the one Tansu mentioned. You might hear diffuse centrilobular nodules, diffuse perilymphatic nodules, or diffuse nodules in a perilymphatic distribution. And then the third one that you can hear sometimes is randomly distributed nodules. Centrilobular nodules tend to be related to airway or diseases that spread through the airways, right? So the idea of centrilobular, there is the smallest functional unit of the lung is called the secondary pulmonary lobule. And it's a sort of a small hexagonal shaped unit of the lung that is the individual lobules that make up a lobe. At the center of the lobule of the lung is the airway, and then the main vessel that feeds that lobule. Now, it's important to note that there are blood vessels all throughout the alveoli and the lungs, but there's a main vessel that feeds each of the alveoli. And then, of course, there's capillary beds all throughout the lung. So centrilobular, at the middle of the lobule, is the airway. And then around the edges of the lobule, if you look at my fingers here, I guess around the edges is where the lymphatics tend to run. And so when you see nodules distributed in a perilymphatic pattern, what that means is that there's nodules that are sort of around the edges of the secondary pulmonary lobule. And then the last one is random. And random means just that. There are nodules scattered all throughout the lung in a very random fashion. And that tends to be related to diseases that spread through the bloodstream, right? Because we said that blood goes everywhere in the lungs, all right? So centrilobular equals airway diseases. That could be airway infections like pneumonia. That could be airway-related interstitial disease like hypersensitivity pneumonitis, right? We inhale allergens through the airways. And so hypersensitivity pneumonitis can have centrilobular nodules. And it could be airway spread of cancer, like endobronchial tumors that are causing nodules via endobronchial spread. Perilymphatic diseases tend to be the ones that Tansu mentioned, sarcoid, for example, and then also the pneumoconioses. And then sometimes we get lymphangitic spread of cancer, right? You may have heard the term lymphangitic carcinomatosis before. That's when cancer metastasizes to the lungs from a distant site, but rather than going through the common path of the blood vessels, it goes through the lymphatic vessels instead. And then the third one is random nodules, and those are things that disseminate through the lungs via the bloodstream. That could be disseminated infections like TB, endemic fungal infections, and the one I want you to not forget is septic pulmonary emboli, right? Because vegetations from the right heart, septic emboli can shower the lungs through the blood vessels and cause a random distribution of nodules, okay? The other randomly distributed nodules can be metastatic or hematologic dissemination of cancer, right? But the big thing is once we know the pattern, we can say, okay, is this an airway disease, a lymphatic disease, or a bloodstream disease? So that's where our focus is going to be. The other thing that I oftentimes will look for is to say, does this cavitate or not? Diseases that tend to cavitate include infectious diseases, sometimes cancers, and a very small number of autoimmune diseases, most notably GPA, right? So GPA as a vasculitis can have a random distribution, again, blood vessels equals random distribution with cavities, as can miliary spread of mycobacterial disease, as can septic pulmonary emboli. So we sort of triangulate between the distribution and then the presence or absence of cavities to help narrow our differential, but oftentimes we're relying on other studies beyond imaging to establish the diagnosis, right? But even from this, right, we don't necessarily know where we're going to arrive, but we've been able to chart a path through how we're going to analyze this case just from being able to understand the anatomic distributions of lung nodules and the significance of that distribution. All right, Yusuf, tell us more here.
I'm going to give you the information to be true to the case, exactly like it came to us. So
Perfect.
he moved to the US 9 to 10 years ago from India. About 2 months ago, he started having shortness of breath, presented to the neighboring hospital. He was treated for community-acquired pneumonia with antibiotics, did not resolve. And then at that point, got a CT scan, which showed the nodules. He was hospitalized at that time. In that hospital, he was also found to have lymphadenopathy. He got a biopsy of that lymph node, which showed necrotizing granuloma. The TB PCR was negative at that time, and the AFPs were negative. So they initiated him on right therapy, and they were waiting for AFB cultures to complete like 6 weeks to rule out TB. And he's presenting to us for a persistent dyspnea, essentially, and no improvement on right therapy. So on review of systems, he does have fevers, chills, night sweats, weight loss, and blood-tinged sputum. He does not have any past medical history. He only takes the right therapy and the vitamin B6 with it. No family history. Social history is he works at a gas station, doesn't smoke, drink, or use any substances, and doesn't have any allergies. And I'm going to stop there.
Awesome. All right. So a rich amount of information. And before we even decide what each of these mean, I want to ask you all to just put in the chat, which pieces of information are you the most drawn to that we've gotten so far? In other words, Yusuf just gave us several different pieces of info. Go ahead and put in the chat which of these you feel like carry the most significance, right? Is it the granulomas? Is it the necrotizing nature of the granulomas? Is it the lack of response to RIPE therapy? Is it the fact that it's a non-resolving pneumonia? Is it the review of systems? Which pieces of information are carrying the most weight for you right now? I see Yaz mentioning the lymphadenopathy and necrotizing granuloma. Tell me more, Yaz.
Yeah, of course. Because you mentioned also like malignancies as the cause of a diffuse nodularity. And now seeing that he has lymphadenopathies and necrotizing granulomas, one of the first things I would add in my workup will be looking for Hodgkin lymphoma and all the different like anaplastic large cell lymphoma and all the subsets. And of course, there are some, I just like sharing this ID pearl because Shema was the one to show me about it. Like there are infections endemic from India, like melioidosis, that can cause necrotizing granulomas in lymph nodes. I don't think that he may have this last one because Yusuf just mentioned that he moved 10 years ago, if I'm not wrong. So yeah, my workup would be mainly the malignancy, like looking, as Hussam also mentioned, the symptoms and other things.
Excellent. All right. Yes. Thank you so much for that. That is absolutely phenomenal. And then Hussam, I'm going to come to you if it's okay with you. Tell me more about the significance of the B symptoms and the lack of response to therapy for you. How is that guiding the way that you're thinking about this case?
Yeah, thank you. Actually, this is my first time here. Thank you for the opportunity.
Welcome. Where are you joining us from?
Right now I'm in Qatar. It's actually 2 a.m. in the morning.
Wow. Well, thank you so much for being here, period, let alone at a very difficult time of the day, at least for me, to be awake and thoughtful.
Yeah, thank you. Actually, the presence of fever, night sweats, and weight loss with the lack of response also would let me to think about lymphoma as my top differential. And definitely include blood workup and maybe bone marrow biopsy as well.
Excellent. Excellent. Thank you so much, Hassam. I'm with you. The lack of response to therapy for me is actually, I think, painting an important, or I should say, it's opening an important door for us to go through. And that's the door of failure to respond to antibiotics, right? And there's about 5 reasons that people may fail to respond to antibiotics, right? We could be treating the wrong bug. In this case, right, he's gotten antibacterial therapy and antimycobacterial therapy. We could be using or treating the wrong bug, but using the wrong drug. For example, this could be TB, even though the PCR was negative, and it may just be a drug-resistant strain of tuberculosis that needs more aggressive therapy. So wrong bug, wrong drug. There could be a source control problem, right? Maybe we're actually missing a small pleural effusion or an empyema. That seems unlikely because we've had cross-sectional imaging, and it's pretty rare for infections to hide, or I should say thoracic infections to hide from cross-sectional imaging, but we can keep it in the back of our mind. The 4th category, which I think certainly comes into play given what you all have mentioned, is node bug, right? This is actually a non-infectious process that we're dealing with. And you both have given great examples of non-infectious diseases that can have pulmonary manifestations, mediastinal lymph node manifestations, and granulomas on histopathology, most notably lymphoma. I'm going to add another disease category to the no bug frame when we think about non-resolving pneumonias, and those are going to be the small vessel vasculitides. Both GPA and the less common eGPA can cause symptoms consistent with a non-resolving pneumonia. And while we usually think about small vessel vasculitides as being diseases that are characterized by a rash, renal involvement, nervous system involvement, and the lungs, sometimes the lungs get hit first, and then we see the rest of the disease erupt going forward. So it's important to keep those in the back of our mind, both because GPA, right, the granuloma is in the name, granulomatosis with polyangiitis, but also GPA can cause necrotizing granulomas because if we think about it, the vascular inflammation leads to local ischemia and possibly necrosis as well. So that non-resolving pneumonia or failure to improve with antibiotics opens up those 4th categories. The 5th one is just that it's too soon. And this is really relevant for the first couple days of infection. This is the patient who comes in with a bad pneumonia and maybe it takes them 72 hours to turn the corner. And we're like, oh man, it's day 2, they should have gotten better. We might need to give it an extra day. In this case, this has been months of symptoms and it sounds like weeks of therapy. So we can take that 5th one off the table. But if we think about, is it the wrong bug, the wrong drug, a source control problem, or no bug at all, right? Wrong bug certainly comes to play. There's a lot of other fungal and mycobacterial infections that we haven't tested for yet. And no bug at all comes into play, given the possibility of underlying cancer or autoimmune disease. And so at this point in time, what I would actually be curious about is what's going on everywhere outside of the thorax in this case, right? If we look into the abdomen and see that there's diffuse lymphadenopathy in there, maybe that makes a stronger case for lymphoma. If we check his renal function and a UA and see that there's some blood and protein in the urine, maybe we start to invoke a small vessel vasculitis and glomerulonephritis. If we look at his shins and see a purpuric or petechial rash, if we notice that he's developing mononeuritis, right? So we're going to turn our attention to say, is this a disease that's characterized by primary pulmonary involvement only? which tends to be the case for most of the, or I should say for some of those infections. We may see the liver and the spleen with some of the disseminated fungal infections, but if we see a disease that erupts in the lymph nodes or that erupts in other organ systems, we may have to turn more of our attention to the non-infectious bugs. But I think for all the reasons that you all mentioned, the base rate is going to favor infectious diseases, and we'll fold in the cancer and the autoimmune disease as we check off some of those other mycobacterial infections, mycobacteria-like infections like what Yaz mentioned, and the endemic mycoses as well. All right, Yusuf, where did things go from here?
Yeah, this is a 30-minute session, correct?
Yeah, if people need to leave, I have a little bit of time, and this is a great case, so we can keep on going.
Okay, I'll give you the full data. So temperature was 39.0, his heart rate was 110. His blood pressure was within normal limits. He was saturating 98% on room air. On exam, he was just a cachectic gentleman. No, his BMI was maybe 19. His no lymphadenopathy was palpable in HENT exam. And his cardiovascular exam, we had like some mild crackles intermittently. Otherwise, his exam was not notable for any rashes. And just for the basic labs, his white count was 12.0 with 75% neutrophils, and his absolute
the white count was, sorry, did you say the white count was 12 or 20?
12.
12, okay, thank you.
75% neutrophils, and the absolute eosinophil count was 500.
Okay.
His hemoglobin was 10 with an MCV of 78, and the platelet count was 500. The chemistries were essentially within normal limits, and I'm going to stop there.
All right. I will be totally transparent. We know that he is inflamed, and we have known that he is inflamed. I have a hard time making a ton of progress from the labs alone now. You know, I think if we wanted to really start to split hairs, we could say, oh, wow, this looks like it's a thrombocytosis here. A thrombocytosis, you know, we can sometimes see that in solid organ cancers, certain rare hematologic, or I shouldn't say rare, but certain myeloproliferative neoplasms. And then it can also be a feature for sort of smoldering inflammatory autoimmune diseases like some of the small vessel vasculitides that we've talked about. But if I'm being honest, that doesn't carry nearly as much weight as some of the other data that we already have which is the imaging findings and the exposure history to various endemic infections that this gentleman carries by virtue of where he has previously lived in the past. And so I think if I'm being authentic to the case, like I see these labs, they paint a picture of smoldering chronic inflammation, but I don't know if they tilt the scales towards any one category of disease quite yet. But I'm very curious to see if retrospectively we look back and I'm like, oh yeah, look, those platelets were a sign of underlying progressive cancer, or those platelets were a sign of an underlying progressive autoimmune disease. And then of course, all of the infections that we talked about, particularly TB, can cause a very consumptive picture that leads individuals to become cachectic and can lead to a thrombocytosis like this. So I think with the labs, everything that we've talked about is still on the table, but maybe with some advanced imaging or some other studies, we'll be able to start to prioritize certain diseases over others.
Yeah, so I'm going to give you the initial imaging. So
Great.
the repeat imaging essentially showed multifocal bilateral pulmonary nodules and masses, some of which have central ground glass. In addition to mediastinal and mammillary lymph nodes, close to 1 centimeter in size. The CT of the abdomen was normal. I can give you some of the labs if you want as well, or should we stop here?
Why don't we just stop here and talk briefly about the imaging here? So we got some interesting features about the imaging. One, we know that there's multifocal nodules and masses. I'm assuming that there are just some that are big and bulky in size and some that are going to be smaller nodules. Yusuf, none of those were cavitating, correct?
That is correct.
Okay. And then we also have lymph nodes in the chest, but it sounds like not much anywhere else. I think, again, all of the disease categories that we thought about are still in play. But one of the things that I'm struck by is actually the absence of findings in the abdomen. So for example, let's talk about TB for a second. When TB causes random distributions of nodules, it can certainly cause lymph nodes within the thoracic cavity, but it also tends to disseminate through the reticuloendothelial system. And that can sometimes lead to the development of granulomas in other places, or we can see sites of disease in other places in the body. For example, that may manifest as splenomegaly. You can see sometimes calcified splenic granulomas. We can sometimes see hepatomegaly, and then we may see various signs of bone marrow suppression. Maybe the hemoglobin here is a sign of that, but this gentleman has many reasons to be anemic, just given how ill he has been. And so when we think about disseminated mycobacterial or fungal infections, I think one learning point that I want you to take home is that they tend to disseminate through the reticuloendothelial system, which is the lymph nodes, the spleen, the liver, and the bone marrow. The absence of findings in those organs on the abdomen and pelvis, to me, turns down a little bit the possibility of infections. I think that they are still prominent infections, but knowing that there's no other signs there turns down the possibility of those. And I think by virtue of that, turns up a little bit some of the other underlying autoimmune diseases and potentially cancers that we talked about as well. What do we make of the lymph nodes? Well, if we think about the categories of disease that we talked about, disseminated infection, disseminated cancer, and autoimmune diseases like small vessel vasculitides, all of those can cause lymphadenopathy, right? Cancer can metastasize to the nodes, and diseases like GPA and EGPA can cause lymphadenopathy just by virtue of the granulomatous process that they develop and the underlying systemic inflammation. And so I think at this point in time, it's hard to make progress based off of the imaging, but we can make progress with some of the serologies, right? We can look for ANCA testing to see if there's any signs of an ANCA-associated vasculitis. We can start to send serologies for some of the other endemic fungal infections we talked about. We might send a histoplasma urine antigen. We might send complement fixation and testing for diseases like blasto. And then we may think about, if we need to, either repeat tissue sampling to get a bigger chunk of tissue, or potentially, yeah, I think I would say that's where we would go. ANCA testing, endemic fungal infections, potentially tissue sampling, or maybe bronchoscopy to get more clarity on what pathogens could be there, or again, for some of the ANCA tests, thinking about underlying small vessel vasculitis.
Jack, I was wondering if the eosinophil count of 500 is not high enough to trigger a change in thought process, or does that impress you or not? I was just wondering.
Yeah, I would say it's something that I'm noting, but I think it's not, how do I say this? I think it's not enough to overcome some of the other features that we might expect to see for something like EGPA. Most individuals who have EGPA usually tend to have a background of asthma or atopic diseases here. And I think the eosinophil counts can be low level like this, or they can be very, very high. I think if we falsify some of the other competing diagnoses, like there is definitely no infection there, this is certainly not a cancer, we're left with the small vessel vasculitis. And if the ANCAs were positive, I think then I would be like, oh gosh, well, do we call this GPA or do we call this EGPA? Is that eosinophil count high enough? But I think if I'm just being honest, the base rate of EGPA is so low that I think this eosinophil count, it certainly keeps it in the picture here. But at least for me, and again, I could be very, very wrong about this, it doesn't carry as much diagnostic, it doesn't overcome the very, very low base rate of it relative to the other diagnoses that we're considering at this point.
Thank you. I'd love to see how you think about it. So initial labs after that, so we were working up the anemia. So the ferritin was 100. The transferrin saturation was 9%. The B12 level was 180, and which is low, and the folate was within normal limits. His HIV screen was negative. A cryptococcal antigen was negative. A urine histo was negative. A quant gold was negative on multiple occasions, like this time and on prior hospitalizations as well. Hepatitis panel was negative. And then beta-D-glucan and galactomannan were also negative from a prior hospital stay as well. Let's see. And then his rheumatoid factor was positive, ANA was negative, and his complements were within normal limits. And I'm gonna stop there.
All right. So it sounds like the major progress that we have made here is sort of at least decreasing the probability of many of the mycobacterial and endemic fungal infections that we talked about here. The rheumatoid factor being positive, I think for me is doing a little bit in terms of maybe again increasing the possibility of an underlying autoimmune disease, but there's so many other non-connective tissue or non-autoimmune diseases that can cause a positive rheumatoid factor. For example, endocarditis, people can have a positive rheumatoid factor. Some of the infections that we've decreased the probability of, the rheumatoid factor can also be high. So this is maybe like showing us that maybe there's some smoke in the area of autoimmune disease, but I think it hasn't necessarily risen to the level of the fire. I think for some of the autoimmune diseases that we're talking about, the more specific antibodies, like particularly ANCA antibodies, would carry much more diagnostic weight because again, RF positivity can happen across the spectrum of diseases, not just in autoimmune diseases.
Yeah. So we spoke to the specialists. So we spoke to pulmonology and infectious disease, and they both recommended continuing gripe therapy in the interim while we try to figure out what is going on, or there's like a competing diagnosis. Given the low B12 and the low iron, we sent celiac serologies, and the tissue transglutaminase came back positive, IgG and IgA. We sent the P-ANCA and the C-ANCA. The P-ANCA was negative, but the C-ANCA was strongly positive. A UA was within normal limits, and a urine protein to creatinine was also normal.
All right, so it sounds like we have ANCA positivity here, and particularly in the C-ANCA pattern here. Just to talk a little bit here about ANCA-associated vasculitides and what all of them mean. So there's different ways that we can test for ANCA antibodies. They can be tested through looking directly at the immunofluorescence, and that can get a specific pattern of immunofluorescence, central or peripheral, and that would be C-ANCA or P-ANCA. And then sometimes we can also test for certain subtypes. So you might hear MPO positive or PR3 positivity. These just relate to the different ways that we can further characterize or classify somebody who has positive ANCA antibodies. In this case here, the C-ANCA being positive helps us a little bit here in the sense as we're contending with, is this GPA or is this eGPA? GPA tends more often to be an ANCA positive disease, whereas eGPA is variable. When eGPA is an ANCA positive disease, I believe that it tends to be more likely to be P-ANCA positive as opposed to C-ANCA positive, whereas GPA tends to be P-ANCA positive. Again, that's not a perfect split here, but if we think about whether this case aligns more with eGPA or not, we don't necessarily see the background of asthma, atopy, and many of these other clinical features. But it certainly isn't necessarily off the case here when we have this absolute eosinophil count that is slightly elevated here, or at least not perfectly normal. The one thing that I would mention is that if you all want to have your mind bended a little bit here, there is a phenomenal case written by many names who you may know, from the CP solvers, including people like Dr. Sarah Goglin, Dr. Dan Minter. I believe that the one and only Dr. Jiha is on this case, where it actually was a mycobacterial infection that ended up being having some positive ANCA values. So before we definitively say that this is a small vessel vasculitis, I just want to introduce that sort of mind-bending pearl here. But I think, Yusuf, you and your team have done a phenomenal job of decreasing the probability of the various infections quite well here through a variety of different tests. And I think with this C ANCA positive, I would favor, I think we can at least start to explore the possibility of a small vessel vasculitis like GPA. But I think the ability to discern between GPA and eGPA within any degree of comfort or certainty is beyond my wheelhouse at this point, but hopefully the rheumatologists were able to help you all out. And I would love to hear how you all were thinking about this, both the significance of the ANCA positivity, specifically the C ANCA positivity, and kind of how you all were handling that at this point.
Yeah, I think this was a discussion basically every single day. We would have like a very, very long discussion, and then someone would say, but it could still be TB. And then we would say, yes, it could definitely still be TB, but we're, as you're mentioning, trying to lower the probability as much as we can. So in order to do that, we got multiple sputum samples again, and the AFBs were still negative, and repeat TB PCR was also negative. And we consulted rheumatology, and we had a multimodal team, including rheum, ID, and pulmonology, in regards to how to best approach this. And infectious disease, we're thinking, in addition to the serologies, they were also mentioning how the distribution of the pulmonary disease is not favoring the upper lobes as the typical TB does, and they would make that less likely. They feel more confident to potentially start immunosuppression and to consider the diagnosis to be most likely as GPA. So in work with rheumatology, the patient was started on corticosteroids and is still getting worked up for other etiologies. And we're going to talk to renal to start other therapies as well.
Amazing. Awesome. Yusuf, I'm curious, how did you learn anything from rheumatology, or just from, I'm sure, the buckets of your own reading that you've done about this on the significance of the eosinophil count? Again, I shared what was in my mind, but to be totally open to the group, there's a very high likelihood that that is an incorrect formulation of the eosinophilia here.
Yeah, so in speaking with the fellow, he mentioned how the higher the eosinophil count, the higher the likelihood of disease, and that higher eosinophil counts typically are associated with the spectrum of disease, particularly cardiac manifestations. And in this case, the degree of manifestations were much higher than the degree of eosinophil count, as you were mentioning. And that is what lead them more towards GPA than eGPA, essentially. I was trying to see if there's any other infections that are associated with eosinophilia, which the guidelines for eGPA recommend a screening for Toxocara and Aspergillus, which were also sent out and were negative, just to round out all the corners and make sure everything is worked up.
Awesome. Phenomenal. Wow. What a absolutely wonderful case. Thank you for bringing this, Yusuf. This is, I mean, like, yeah, there's so much learning here. And I really appreciate you sharing this with us. Anything else that you learned or feel compelled to share that feels particularly important before we turn over the teaching points to Kushal?
To be honest, the tissue transglutaminase surprised me as to, like, does the patient also have concomitant celiac disease?
Yeah.
And is there like an association between celiac disease and other vasculitides? I'm still doing my research on that, and the patient will be referred for tissue sampling as well for EGD eventually to confirm the diagnosis of celiac disease. But in the interim, we are pursuing a gluten-free diet, but that is something that I'm still want to read about.
Right on, right on. Thank you so much, Yusuf. This was a phenomenal case. Kushal, take us away with the teaching points.
Yeah, hi. So it was an amazing case and great discussion. And I was also surprised to see how the whole discussion was going. And there has been multiple GPA cases presented earlier with various presentation. And the main teaching points are, if you have a diffuse lung nodules, consider the pattern of the distribution. If it's central lobular, think of infections. If it's perilymphatic, think of pneumoconiosis or lymphangiectatic spread of cancer, or if it's random, then disease which is spreading through bloodstream, and do not forget about the septic pulmonary emboli. And also consider if the patient, the nodules are having cavitation, if they're necrotizing. If it's necrotizing granulomas, think of Bartonella, pseudomyelin, coccidiomycosis, blastomycosis, histoplasmosis, crypto, and TB. And GPA has random distribution with positive cavitation, and they're also necrotizing. And they would also have other system involvement, like either rashes, renal involvement. And if the person is presenting non-resolving pneumonia, consider it's either wrong bug got treated, or if it was the wrong drug which was given, or the source control was the problem, and if it was no bug, like an autoimmune disease, or it's a small vasculitis. And it's always important to also assess if it's only pulmonary involvement, or if there's involvement of other organs, like either for instance, if it's disseminated tuberculosis or fungal, and they spread through, they would be involvement of the liver and spleen would be there, and also other lymph nodes would be there. So, and the other important thing which I did learn was about the base rate of eGPA, where it's low. So you would have to start considering that later when you start ruling out other conditions. And Yusuf was mentioning that it could always be TB, so it's important to test for TB again before ruling it out completely. And RA can be positive not only in autoimmune disease, but also in non-connective tissue conditions like endocarditis. For C-ANCA, when they're positive, GPA is more common than eGPA. And if eosinophils are very high, think of eGPA more than GPA. And for this patient, there's tissue transglutaminase was positive, and they're still working on to see if the patient is having some other underlying IBD, or if it's just because of this condition. And it would be great to know at a future date what Yusuf finds.
Amazing. Kajal, what a phenomenal distillation of an incredibly dynamic case. Yeah, thank you so much to you and to GF for all the work on the whiteboard today. Team, thank you all for sharing your thoughts, analyzing the case along with me, and really advancing this discussion through quite a challenging case. We covered a lot here. I had so much fun, and I look forward to seeing you all soon. I hope everyone has a wonderful rest of the day. It was great to see some new faces, and I hope to see them again soon. Take care, everyone.